Okay, before we begin, can I ask, some of you have had sessions regarding newborn examination yesterday, is it? And today? Huh? Anyone?
Group one. Okay,
Huh?
group one.
One group. Which group? Your group?
Group one with Dr. Mossad.
Group one with Dr. Mossad, newborn examination. Did you, is it done as practical or online?
Practical.
So you went to the NICU?
Yes. Then Dr. said if no case in ICU, we'll conduct in PITS ward.
Okay, all right. So one group, so but you haven't got the lecture about newborn exam yet? Ke dah ada dah?
Not yet.
Not yet. Okay, all right. And another group has had the session with Dr. Alwi, is it?
Yes, doctor. Group 2.
So two groups already have sessions regarding newborn examination.
The other group will be having it at 10 a.m. today
With whom?
with Dr. Mossad.
But one group already have with Dr. Mossad yesterday.
Sorry doktor, dengan Dr. Alwi yang dah dengan Dr. Mossad pagi ni lepas ni.
Okay, all right, fine. Okay, I should have 3 sessions with you then. So one is the lecture on birth asphyxia. Another one is the lecture on newborn examination, and then there should be one group who should have practical session with me on newborn examination, isn't it? Which group that has session with me?
Group 3, doctor.
Group 3. Okay, all right. We'll see. What we can do is okay, what we'll do is, because we don't have that much time, so probably now I'll give you the talk on newborn examination, and then group 3 we'll do the session with group 3 at 2 p.m. today, and then the birth asphyxia we just need to look for some other time. So if you want, we can even do the birth asphyxia talk. We can even do tomorrow morning at around 8:30 if you want, but we'll see. Okay, all right, fine. Let me look for my presentation. Okay. Okay, can you see my slide?
Yes.
Yes.
Okay, all right. Fine. So what I'm going to talk today is regarding newborn examination. I know one of the group has already had the session with Dr. Alwi, but that's fine. So newborn examination is basically one of the most important assessment or examination on a newborn. The other thing is that because you've all got the lecture with Dr. Mossad on newborn resuscitation yesterday, isn't it? Did he tell you how many? Did he tell you how many percent of newborn need some degree of resuscitation? So it's a huge number. So in most newborns, they when they are born, they are able to breathe normally, they can cry normally. But more than 40% of them, they need some sort of stimulation. They need some sort of stimulation for them to begin breathing. Because we assume breathing as something easy. But for newborn, sometimes it is a struggle. It is a struggle. Okay. So newborn examination is a type of assessment that we do on newborn babies. There are several phases. We do at birth within the first hour of life. We do at 2 to 4 hours. We do after 6 hours of life. We do within the 72 hours, and also we do in 6 weeks. Depend on the setting and depend on the capability of the unit. But this is the type of assessment that should be done in all newborn. Every newborn baby has the right to be properly examined by a competent personnel that is able to do proper newborn assessment. And as such, as we are assessing all newborn babies, every newborn baby should be assessed, should be examined. So majority of them, 90% of them should be normal babies. You know, when you do physical examination, if you have, I think many of you have had sessions with me. Is it many? I don't know. You've all ada session with me buat long case kan? Ada tak? Ke tak ada lagi? So I always tell medical students, when you get history, you need to know your provisional and differential diagnosis, because you will only get good history if you know your provisional and differential diagnosis. You will only do proper and good physical examination when you know your provisional and differential diagnosis. These are in children who has some sort of disease, who has some sort of problem. But with newborns, majority of them don't have any problem. They don't complain of anything. So this is a matter of us as medical personnel. We are housemen, we are medical officer, we are medical student, we are specialists, we are neonatologists, we are whatever, we are nurses, midwives. When we do newborn examination, it is very important for us to know what we are looking for. And majority of them are normal babies. So I always tell students, when you do physical examination, the most important thing, so for example, when you go for short cases, when you do short case, when you do modified long case, when we expect you to examine patient, what do we look at? The first one is your approach, whether you are safe doctor, how do you approach that presentation? Second is we look at whether, we look at your technique, whether your technique is proper, you perform the physical examination properly. And then third, we look at whether you are able to identify normal. Because sometimes you can never identify something abnormal without knowing what is normal. And then fourth, only we assess whether you can identify a abnormal finding. So identifying normality is very important, especially for newborn. You need to know what is considered as normal and what is considered as abnormal. Yeah? Okay. And then you also need to know what are the risk factors associated with certain maternal condition. For example, I give you certain example. When the mother is of old age, age more than 35 years old. So elderly mother, 35 years old is considered as elderly. And so elderly mothers, there's an increased risk of trisomy, Down syndrome, for example. Kan? Or mothers who have diabetes, diabetic mothers. So diabetic mothers, the newborn babies are at risk for apa? Sacral agencies, kan? mothers who do not take B12 and folate, for example, the babies are at risk of apa? Spina bifida and so on and so forth. Kan? Mothers who take certain drugs, for example, what are the problems? Kan? Mothers who take cocaine, for example, what are the risks associated with their child? Kan? Mothers who have hypertension, what are the complications that may happen to the child? The child may be IUGR, for example, at risk of hypoglycemia. So when you do newborn assessment, it is just not it is not just about the baby, it is not just about assessing normality, but it is also knowing what is the problem with the mother and assessing whether the child has those complications associated with the maternal condition. Okay, all right, fine. So this is the most thorough perinatal exam. So perinatal means surrounding delivery and after delivery. It must be done by undergraduates, graduate, postgraduate doctors, I've mentioned before, and we do several phases. We do at birth, we do within the first hour of life. Certain examination we do need to repeat within 1 to 3 hours of life. And most of the perinatal, most of the newborn examination we need to do within we need to do after 6 hours to 72 hours of life. Okay, and then we go phase by phase. The first one in the delivery room at birth, and also within the first hour of life. So what do we, when we examine the baby, what do we look for? We look for whether we look for the adaptation for extrauterine life. I think you've had the lecture, isn't it? Adaptation to extrauterine life. So how the changes in terms of the cardiovascular changes, okay? How the baby behaves in terms of breathing and so on and so forth. You need to look for those physical and physiological changes that shows that the baby is adapting well to extrauterine life. You do APGAR score. I'll go through APGAR score later. So APGAR score is the assessment of the condition of the baby at birth. You look for dysmorphism. The thing is, at birth, usually the first 24 hours, sometimes dysmorphism ni a bit difficult. Sebab almost all babies, at birth, the first 24 hours, they are a bit edematous. So dia punya muka akan nampak sembab sikit. So bila dia edematous, sometimes they may look a bit dysmorphic. But it's not because the child is actually dysmorphic, it's just because they are edematous. So sometimes when you see something, you probably need to reassess again after 24 hours or so. You look for major congenital anomalies, whether there's any obvious congenital defect, whether there's any birth injury, Erb's palsy, shoulder dystocia, fractures. I've seen babies born with femoral fracture. I've seen babies with humerus fracture, clavicular fracture many times. So these are all birth injuries. You look at the umbilical cord, whether it's normal or not, whether there's some abnormality with the umbilical cord, and then you assess for the gestational age, because sometimes by scan, by date, the assessment of the baby is different. But when the baby is born, you assess the baby and then you look at, oh, actually the gestational age is actually different, because there's a baby who's born 30 weeks is definitely different as compared to a baby that is actually term. Kan? I remember last time we had our discussion with the Mufti of Pahang and the team, Jawatan Kuasa Fatwa Pahang. We discussed about, we presented about our breast milk bank idea. But what I'm trying to say is, when we were discussing, when we had our lunch, the Timbalan Mufti was mentioning about the issue regarding extramarital conception. Maknanya they conceive a child out of wedlock before getting married. So how can they put bin or benti to the biological father, whether it is after marriage or before marriage, because sometimes the marriage is only, so the fatwa now is after 6 months. If the baby is born within after 6 months marriage, then they consider the baby can be put bin or binti to the biological father. But if not, then they need to put under Abdullah or something. The thing is, they asked me, so I said, if the baby is born, even though parents can claim uh, by by date, it's actually more than 6 months, and by scan, it's probably more than 6 months. But the most proper assessment is our assessment at birth. When we see the baby, we can actually assess, and we can tell, we can check whether the baby is actually term, or what is the actual gestational age. Okay, wait, let me, okay, all right. Give me 1 minute. I have a case to discuss. Okay, sorry. Today is my clinic day, so it's a bit busy for me. Okay, all right. So where we are. So we look at the gestational age of the baby. I'll show you how we assess the baby in terms of the gestational age. We assess for the cardiorespiratory, and then we assess the thermoregulation, whether the temperature of the baby is right or not. Okay. And then we look at identification of the baby, medication the baby is on, and the mother is on as well. We look at the passage of urine and also meconium. If the baby doesn't pass meconium, so you need to think of something. Whether is it there's meconium plug or something. Sometimes failure to pass meconium is a sign of certain diseases such as cystic fibrosis. Cystic fibrosis. Or things such as Hirschsprung disease or something as well. Okay, what is ABGAS score? So ABGAS score we assess at 1 minute, and then 5 minutes, 10 minutes, 15 minutes, 20 minutes. But at least it needs to be assessed at 1 minute, 5 minutes, and 10 minutes. So especially most important is the 1 and 5 minutes. So identify the need for neonatal resuscitation and diagnosis of perinatal asphyxia, and it is good for prognostication as well. So what do we assess during ABGAS score? We assess respiration, crying of the baby. Because if the baby can cry, definitely the baby can breathe. Can you cry without breathing? Ya, nangis tapi tak bernafas. Tak boleh lah kan? So for you to cry, you need to be able to breathe. Tapi sometimes dia ada orang panggil apa, nangis selok tu. Tahu nangis selok? Dia nangis tak berhenti. Selok tak berhenti. Ataupun dia jenis dia tahan nafas. Dia nangis tak ada suara, tak keluar apa tak keluar. Not inspiring, not even expiring. Ini certain children ada. And then we assess the reflex of the irritability of the baby. We look at the pulse, the heart rate, skin color, and muscle tone. So how do we score? This is how we score the baby. So color, heart rate, and pulse, reflex, irritability, grimace of the baby. We look at the muscle tone. We look at the respiration, and then we score. 0 means bad lah, die lah baby. And then 1, 2, so the full score is 10. Full score is 10. So acrocyanotic meaning cyanosis at the periphery, at the distal, at the tips. And then heart rate. So normal, what is the normal heart rate for newborn babies?
110 to 160.
So yeah, it can go up to 150, 160. And then we assess the movement, muscle tone, motion, movement of all 4 limbs, and then respiration, whether it's irregular or is it good. What are the other signs of respiratory distress? So cyanosis. So cyanosis is a sign of respiratory distress. So newborn babies, unlike adults, the most problem for newborns is actually respiratory. If they collapse, most likely if they collapse at birth, most likely it is because of respiration, respiratory failure. It's not because of cardiac failure like in adults. Grunting. What is grunting? Grunting apa grunting? Grunting ni is an English term lah. Dia bukannya medical term. Kita orang Melayu kita tak faham kena grunting ni apa. Grunting ni grunt ni macam mana? Grunt ni macam that is grunting. That is grunting. Tapi macam mana newborn dia grunt? Dia grunt dengan cara macam mana? Dia close dia punya vocal cord, dia tutup vocal cord, and then dia try basically nak increasekan intrathoracic pressure. Macam tu, dia tutup vocal cord kan, tutup dengan tekak kita belakang ni, you tutup vocal cord and then you macam you tekan nak buang air besar yang keras tu. That is grunting. So dia breathe macam tu. Sebab apa dia grunt? Sebab you know lung collapse because of RDS, because of pneumonia, lung collapse dan sebagainya. So bila dia increase ke intrathoracic pressure tu, try to open up the lung. So grunting is a sign of distress. Flaring of the nostril, kebang kecut hidung dia. Chest retraction, heart rate, respiratory rate. So newborn babies, they may have respiratory rate up to 60, still normal. 60 is still normal. So more than 60 is a sign of respiratory distress. So next is about thermoregulation. So it is very important. Maintaining proper thermoregulation for newborn baby is essential. It's extremely important. Why is it important? Because newborn babies, do they have larger body surface area as compared to adults? No lah kan, sebab dia lagi kecil. So adult have larger body surface area, but they have larger body surface area as compared to weight. If you compare adults and newborn babies, even if you compare with larger children, if you compare with other children, newborn babies, they have larger body surface area as compared to weight. So they have more areas for heat loss. So how do we maintain heat? How is heat being transferred? There are several ways: convection, evaporation, conduction, radiation. Evaporation ni macam mana? Contohnya when you have a baby, when you have a child with febrile seizure or a feverish child, apa kita buat selalu? Kita advise kita buat tepid sponging kan. Macam mana orang Melayu biasa buat tepid sponging? Kalau tengok cerita-cerita Melayu kan, cerita Piramli kan, dia letak ais kan dekat kepala kan. Cerita apa tu? Labu-labi. Labu-labi kan, dia letak ais dekat kepala. So untuk kurangkan demam. To reduce temperature, we used to do tepid sponging. But how does tepid sponging help? Several ways. The first one is by conduction lah. Maknanya when the ice or cold water touches the skin, then there's conduction of the heat. That's one thing. Second is by evaporation. So ideally, because there's a hadith. The Prophet said, verily, fever is because of fire, heat. Then the Prophet said, "Fa'abariduhu bil ma'," and reduce or make it cold by water. So this is a hadith yang sahih. So when you do tepid sponging, what you need to do is you don't use cold water, you use tepid water. So room temperature water. So you put on the skin, not too much because you don't want the child to shiver. Bila ketar-ketar shivering, what's going to happen? Muscle, ATP production. So you know your metabolism, movement of muscle uses ATP and the product is heat. You don't want that to happen. You shiver, more muscle movement, ATP usage, heat is produced. You don't want that to happen. So what you want is you put just enough minimal water, macam kita ambil wuduk kan. Certain part kita fa'arsilu, you wash. Fa'arsilu means the water must be dripping. But some parts wamsahu, you just sapu kan. Just that the water just must pass through. So tepid sponging should be just like that. So the water is just there. So then when the water evaporates, when the water changes to vapor, this is how heat is lost. So same as newborn babies, they may lose temperature by evaporation. What are the normal vital signs for babies? Is the same. Temperature is 36.5 to 37.5. Heart rate is 110 to 160. Respiratory rate may maintain up to 60. Oxygen saturation is okay. And then BP, we usually look at the mean, the mean gestational age. So we look at the mean blood pressure. So meaning, for example, a term baby, the mean arterial pressure should be around 40. For a 30-weeker baby, the mean arterial pressure should be around 30. A 32-weeker baby, the mean arterial pressure should be around 32. Macam tu. So we look at a passage of stool, passage of urine. So we need to look at whether a normal child should pass urine within the first 24 hours. A normal child should pass meconium within the first 24 hours. If the child doesn't pass all these things, you need to look for problems, whether there's any problem with the renal or whether there's any problem with the gut. Look for gestational age. How do we look for gestational age? This is what I said before. We do ballot score. So ballot scoring is the assessment. It needs to be done as early as possible. Ballot score, if you do more than 24 hours, it's not reliable anymore. We need to do ballot scoring as early as possible. So this is how we do. We look at the posture of the baby. There's a scoring here. You score, dapat berapa point dia, and then you look at the maturity rating. Dia ada score dia. Score ni bersamaan dengan berapa weeks of gestation. We look at the arm recall. We look at square window. Square window ni mana kita ni kan. Kalau the more term baby dia boleh lipat lagi banyak. More premature dia tak boleh lipat, dia keras sikit. Arm recall dia macam mana, popliteal angle. Kita tengok skin dia, tengok dia punya lanugo. Lanugo ni dia punya bulu-bulu dekat belakang. We look at the plantar surface, plantar creases dekat crease dekat dia punya plantar, dekat dia punya tapak kaki. And then breast dia ada nipple ke tak, ada budding of nipple ke macam mana. We look at the genital and so on so forth. Kita bagi score. With the score we look at the maturity rating, the gestation age, and we give range. You don't give specific, you give range. So these are the quick assessment. You look at those things lah. So more term baby, you akan nampak lagi banyak vernix. Vernix ni benda putih-putih pada baby. Babies, infant of diabetic mother, biasa dia ada banyak vernix, putih-putih dekat dia punya kulit dia. So cracked skin. So this is a sign of a term baby, maturity. More mature the baby, more cracked skin. Lanugo, abundant lanugo. Bawa ni bulu-bulu banyak ni. This is lanugo. And then preterm babies, dia punya ear dia very lembik. You push, you tolak ke depan, dia tak patah balik. Kalau term baby macam you punya telinga lah. Kalau you tolak telinga you, dia akan patah balik ke belakang. Dia akan balik kepada the normal position. More premature baby, the slower it return back to normal. Very premature baby, if you push, dia akan stay like that. So areola, so you see in a very premature baby, areola dia tak form lagi, dia very flat saja, tak ada bud pun, tak ada nipple bud pun. The more term baby you can rasa breast bud. Sole crease, this is a term baby. Bila term baby, the whole sole is has crease. Ada dia punya ni crease dia ni. I don't know what's the term for crease in Malay lah. But the creases there, you can see all the creases. But more premature baby, you won't see. Some extreme premature baby, there will be no crease, and then you will see initially 1/3, and then half, and then so on and so forth. Okay, this is very in mature baby, the labia majora is bigger than the labia minora. The clitoris is not prominent, but more premature baby, the clitoris will be very prominent. The minora will be bigger than the majora. Sorry. Okay, so you see premature baby, you can see the minora is a bit more prominent, and in a mature baby, the majora is more prominent. Minora, you can't even see the labia minora. So male genitalia, you look at what? You look at the scrotum, the scrotum. In a mature baby, you can see the rugae of the scrotum. Ni rugae yang kedut-kedut ni. Kedut-kedut ni are all rugae. Term baby, the testis is descended, You can see the scrotum really well. Dia ada bentuk pouch dia. Lepas tu you can see the rugae. More premature baby, rugae tu tak ada. Nampak licin, flat saja. So resting posture, more premature the baby, tangan dia nampak lebih flat. Kalau term baby, you nampak dia kan bentuk macam tu. Yang sebelah, can you see my arrow tak? Tak nampak
Boleh.
Nampak? Okay, so this is term baby. Term baby dia posture dia macam tu kan. And then more premature baby, dia punya resting posture dia lebih extended lah. Okay, and then we look at the nervous system. We will look at, these are all among the primitive reflex. There's a lot of primitive reflexes. Dia ada head leg tak, morose reflex. Morose reflex ni adalah, let me try. We'll practice do morose reflex when we are in the ward today. So if you have a baby like this, kebetulan ada satu baby ni. So if you have this baby, you drop the head a bit macam tu. So what will happen is bila you macam tu, dia punya baby arms, both arm will outstretch of the arm and it will recoil. So this is a complete morose reflex. It should be symmetrical. In some babies, it is not symmetrical. Asymmetrical morose suggests probably ada some injury. Contohnya apa nama, brachial plexus injury kan. Rooting reflex. What is rooting reflex? So rooting reflex is bila you stroke dia punya cheek, dia akan cari. So this is rooting reflex. Sucking reflex. Sucking reflex maknanya you put anything inside the child's mouth, dia akan hisap. You letaklah apa-apa pun, dia akan hisap. You letak siku pun dia hisap, kan? So the child will suck. So this is sucking reflex. Because these are all primitive reflexes that are essential for the life of the baby. Without sucking reflex, a child cannot live. Kan? Lepas tu apa lagi? Hand, palmar and plantar grasp. Maknanya, if you put something on the palm, the baby will grasp. If you put something at the, kalau ni kaki baby, you put something at the leg, the foot as well, dia ada plantar grasp. You tengok yang tu. Lepas tu apa lagi? Asymmetrical tonic neck reflex. Maknanya kalau kita turnkan kepala dia macam ni, dia akan assume fencing posture. Dia akan buat macam tu. Kaki pun sama. I'll show you some of the picture. Stepping reflex. Stepping reflex ni you contoh ni kaki baby kan. Ni kaki. You nampak my photo ni. Ni kaki baby. Ni kaki kan. You letak contoh ni surface. You letak kaki dia macam ni, dia akan step above. This is stepping reflex. Dia ada walking reflex ataupun dancing reflex juga. You pegang baby macam ni, you letak kaki dia, you pegang hanging macam ni, you letak kaki dia atas satu surface, dia akan macam jalan. You pernah tengok ada satu video viral dulu kan, kata oh baby ni miracle boleh jalan. That's normal. That is a normal walking reflex. Newborn babies, if you hold macam tu, if you suspend ventral suspension and then you put the foot on a flat surface, baby akan jalan ataupun dancing reflex. So that is normal reflex. Head leg. So you assess head leg ni, you tarik the hand macam pull to sit. It's basically pull to sit and you look at head leg. So newborn baby, they do have head leg, but sometimes they memang akan ada head leg. But you see whether there's any marked hypotonia or not. Morose reflex, I've mentioned before, dia punya tangan dia akan outstretch ke tepi dan dia akan recall properly. Tonic neck reflex, as you see here, you turn the head over to one side, dia akan assume fencing position. Maknanya the limbs, upper limb and lower limb, belah yang where you face where you turn the face to, dia akan macam outstretch. Side yang dia opposite side tu dia akan flex. Both upper limb and lower limb. Ni kita panggil fencing posture. Dancing reflex ni walking reflex lah. You buat macam ni, memang baby akan jalan. Memang baby akan macam jalan. That's normal. It's not a miracle. It's normal. If baby don't do this, then you need to think of something. And sucking rooting reflex, I've showed you before. You put anything inside the baby's mouth, the baby should suck. If the baby doesn't suck, that's abnormal. Palmar grasp, plantar grasp, apa kaki dia, the foot it grasp macam tu kan. So plantar grasp or foot grasp. And basically newborn examination is a head to toe examination. You assess from the up, from the head to down. So you look at the head circumference, whether the head circumference is normal or not. You must plot on the growth chart what is the baby's weight, what is the baby's length, and what is the head circumference, whether they are corresponding to each other, whether it is symmetrical. If it is not symmetrical, think why is it asymmetrical. For example, kalau baby tu weight dia is low, is on head dia pula on above 50 centile. So what do we need to think of? Kalau weight dia IUGR less than third centile, length dia IUGR less than third centile, tapi kepala dia more than 50th centile, what do you need to think of?
Hydrocephalus.
Okay, well, what I'm trying to show is actually this is asymmetrical IUGR. This is usually we can see in babies with infants of mothers with PIH, pregnancy induced hypertension. Sebab bila ada pregnancy induced hypertension, there will be reduced perfusion to the baby. There will be placental insufficiency. So bila placental insufficiency, body baby tu tak dapat nak grow. Bila body baby tak dapat grow, weight dia tak bagus. Sebab tu weight dia less than third centile. Sebab tu dia panjang dia tidak also less than third centile. Tetapi what happens is our body will try to protect the head. Sebab tu dia ada some element of head sparing. Sebab tu kepala dia selamat. Sebab kepala is important lah kan. So the body will try to save the head. So dia ada head sparing. So you look at molding. Molding kalau dia lama dekat bawah mother dia sebelum keluar, you akan nampak kepala dia shape lain sikit. That's what we call as molding. Ada caput succedaneum tak? Sama juga because of molding, caput succedaneum macam edema. Edema on the scalp edema, that is caput succedaneum. Atau caput cygnon pun sama juga. Ada cephal hematoma tak? Ada bleeding tak under the skin? So bleeding under the skin ni, dia ada several lah, I'll show you later. And then fontanelle, kita tengok fontanelle ni dah close ke tak? Kan? So kalau fontanelle dah close, dia baby tu maybe ada problem macam craniosynostosis. Kalau dia punya fontanelle dah tutup, sutures pun dah tutup, how can the head grow? How can the brain grow as well? So molding, because of delayed, prolonged labor and so on and so forth. Cephal hematoma, you tengok satu side dia, it doesn't cross the midline. So caput is basically edema. Cephal hematoma, ada dua, cephal hematoma and also subaponeurotic hemorrhage ataupun subaponeurotic hemorrhage ataupun subgaleal hemorrhage. Is the same thing. Cephal hematoma and subaponeurotic or subgaleal hemorrhage, dia adalah bleeding under the skin. So your scalp ni dia ada beberapa layer dia. Layer dia adalah SCALP. S is skin, C is connective tissue, A is aponeurosis, L is loose connective tissue, and P is periosteum. Below periosteum is your skull bone. So cephal hematoma is bleeding under the periosteum. And you know periosteum covers the skull bone. So kalau bleeding kalau cephal hematoma, the bleeding will not cross sutures. Dia tak akan cross midline. Sebab midline ni bone. So dia tak akan cross midline lah, sebab periosteum is bounded by the bone. Sebab dia covers the bone. Periosteum. Tapi kalau subaponeurotic hemorrhage or subgaleal hemorrhage, basically the same thing. So it is bleeding below the aponeurosis, above the loose connective tissue, and it is usually a venous bleeding. So venous bleeding dia susah nak vasoconstrict, susah nak stop. And the slow bleeding. And this subaponeurotic area is a potential surface that connects your whole body. The whole body is connected. So maknanya you can lose blood to the whole body. You can lose 100% of your blood into the subaponeurotic space. Kalau you pernah tengok orang lapar lembu kan korban lapar lembu, you perasan tak dia separatekan skin tu dengan tisu apa semua. Ada area yang putih-putih tu. That is the subaponeurosis. So that is a potential space. You can lose your 100% of blood into the subaponeurosis. So if you have a child with SAH, subaponeurotic hemorrhage, you need to assess. It is, you tahu bila dah ada bleeding, cephal hematoma atau subaponeurotic hemorrhage, ada blood kat situ. What will happen to the blood? Satu, bila bleeding, baby boleh jadi anemic lah, kan? Yang kedua apa lagi? Dia boleh go in shock. Apa lagi? Bleeding, what will happen to the blood? Blood will lyse lah. Dia akan pecah. So bila dia pecah apa jadi? Jadi jaundice. And both cephal hematoma and also subaponeurotic hemorrhage ni is painful. It's tender. Sakit Sebab apa? Sebab dia extend. You know, soft tissue sometimes dia tak ada pain receptor, tapi dia pain receptor ni in terms of stretching of the viscera. So dia boleh painful. You look at the eyes, so you dapat atas kan, scalp. You tengok rambut dia. Sometimes you may see children with alopecia. I've seen quite bad alopecia areata in a baby. And then you look at the eyes. Eye dia macam mana? Proper position tak? Is it single eyes? Kan? Cyclops. I've seen a cyclopic baby. And then ada slanting tak? Nowadays we tend to not. Dulu kita panggil Mongolian slant, Mongolian eyes. Generally now we prefer not to do, but it sounds a bit racist lah. Panggil Mongolian macam tu kan. Sama juga you look at the hands kan. Kalau Down syndrome kan dia ada single palmar crease kan. You see my crease, dia ada line kat sini, ada line kat sini, ada line kat sini. Kalau babies with Down syndrome, dia ada single palmar crease. Dia tak ada yang dua ni. This line straight macam tu. Dulu kita biasa panggil, sekarang biasa panggil lah, we call simian crease. Sebab simian ni monkey dia memang single palmar crease. How dia flex dia punya hand dia. But again, when you label something as animal, it sounds demeaning. So we don't usually tend to call those things now. So rather than simian crease, we call it properly lah, single palmar crease. So whether there's any up slanting, down slanting of the eyes, you look at red reflex. Red reflex ni maknanya you use the fundoscope, but you don't look at the fundus. You just look at the cornea. Whether there's red reflex present or not. Kalau red reflex tak ada, then the child have leukocoria. Kan? Leukocoria, cataract. Then you need to think, what are the causes of leukocoria? Hepatitis B, torch infection. Torch ni apa? Toxoplasma, rubella, CMV, herpes simplex, and syphilis. And you need to look for those things. Or retinoblastoma. Okay. You look at epicanthal folds. You look at whether there's any hypertelorism. Hypertelorism ni maknanya apa? Maknanya you can put another eyeball dekat tengah-tengah. In between the eyes ni, you boleh tak satu lagi eye kat situ. That is hypertelorism. You look at blink reflex, you glabella tap. You tap, dia kena blink. You tap kat sini, dia patut blink. And then you look whether there's any discharges or not. You look at pupillary reaction. You tengok, dia follow midline tak? And then hearing, you assess whether the child responds to hearing tak. Sometimes bila you clap dia akan buat macam moroh, dia terkejut. So that shows that the baby is responsive to sound. And all babies should get universal hearing test. This is very important as well. Okay, and then we assess cardiorespiratory status as well. You auscultate the heart, you look for certain heart sounds. Again, certain murmurs appear later. Contohnya VSD murmur. Why do you think VSD murmur appear later? Anyone has any idea? This is one thing which we've had the session, prime session recently about nephrotic syndrome, isn't it? I promise you we should do another session on cardiovascular and respiratory. So these are among the things that I will discuss actually. So VSD, why you hear VSD murmur? What type of murmur in VSD?
Pansystolic murmur.
Pansystolic murmur. Why do you hear pansystolic murmur? Why do you hear that murmur?
Right, Shan.
Left to right shunt, because the systemic blood pressure is higher compared to pulmonary blood pressure. But you remember, you learn about adaptation to extrauterine life. In utero, the pulmonary pressure is higher as compared to systemic blood pressure. So especially in the first 72 hours of life, the pulmonary blood pressure is still high. It takes a bit of time for the pulmonary blood pressure to actually go down, so that there will be shunting left to right shunt. So usually even if there is large VSD, there won't be that much shunting because of the pressure gradient is not that much yet. Okay, all right. You need to feel the femoral pulses. Kenapa? Kalau tak ada femoral pulse maknanya apa? Name me one disease where you cannot feel the femoral pulse.
Coarctation of aorta.
Coarctation of aorta, yes. Not just coarctation of aorta, aortic stenosis as well. Aortic stenosis. In adult, you would think about aortic sclerosis. My case for my final professional exam in the year 2006. My exam is about I got one of my short case I got was aortic stenosis. Damn, difficult. Okay, all right. Look at how the baby breathes. You assess respiratory. This is intercostal recession. Intercostal recession, subcostal recession below the costal margin. This is not Harrison sulcus. I always see medical students confused di antara subcostal recession and Harrison sulcus. Harrison sulcus is for chronic respiratory problem such as asthma, BPD, cystic fibrosis, bronchiectasis. You may see Harrison sulcus. Harrison sulcus is induration at the T10 level. T10 is the insertion of your diaphragm. Look at grunting, look at nasal flaring, and then feel the femoral pulse. Both side. Jangan rasa sebelah apa tu you happy dah. You need to feel both side. Always look for symmetry. One side should be same as the other side. Tak boleh kalau satu tangan gerak, satu tangan kurang gerak and then you happy. No. If there is asymmetry, it is abnormal. Assess the abnormality. The child should have complete fingers. Kalau tak complete, think why the child is tak complete. Dia ada apa nama amniotic band syndrome ke something kan. The child may have syndactyly, the child may have polydactyly kan. Macam Ritik Roshan kan. Kenal Ritik Roshan? Tak kenal Ritik Roshan?
Tak.
Yo, ada orang tak kenal Ritik Roshan. Not your time probably.
Kenal.
Aduh, hai. Zaman-zaman sekarang ni kan. Kan, Ritik Roshan kan ada polydactyly of dia punya thumb kan. Sebab tu dia always, kalau you tengok dia salam, nak cerita dia semua dia salam macam ni kan. Cover, macam orang tak tahu je. Kan? So, whether the child has polydactyly. You look at the clavicle. Ada clavicular fracture tak? Among the problem with shoulder dystocia is clavicular fracture. You look at whether the arm moves. Sometimes they tak move. Fracture clavicle, fracture humerus. And hips. You always need to look for child with. You need to look for stability of the hips because sometimes dia ada DDH, dysplastic hip. Kan? Dia akan clicky, dia akan click because dislocatable. Especially if there is family history of clicky hips. Look for club foot, CTEV, congenital talipes equinus virus. Dia macam club, macam kayu hoki tu. Also kalau opposite daripada dia apa? Congenital talipes equinus virus. Oh, sorry. Hello? Okay, alright. I think we need to be a bit faster. Okay, so alright, and then look for curvatures, whether there's scoliosis, apa, ada cyst tak, ada sacral dimple ke tak, and reassess. Sometimes we may have problem dekat neck dia. Neck dia boleh ada apa? Dia ada cyst, dekat besar dekat dia punya neck dia. So to check for hip, you do the otolani and balo test. Otolani and balo test. So otolani you open and balo is you close kan. And then look at the hip, you assess the skin folds, tengok belakang dia macam mana, ada sacral dimple, sacral pit tak kan. If ada sacral pit, ada sacral dimple, you need to think ada tuft of hair, you need to think of spina bifida. You look at the genitourinary, whether it's actually male, female, or it's ambiguous genitalia. Is it, kalau ambiguous, is it macrophallus? Is it macrophallus or is it clitoromegaly? Kan? So you assess. Never discharge a baby with ambiguous genitalia. Ambiguous genitalia is among the emergency that you need to settle. Another thing is passage of meconium does not mean the anus is patterned. Passage of meconium does not mean the anus is patterned, because meconium can pass through if there's any, sometimes there is a passage from the rectum to the vagina. I've seen one. People miss imperfect anus because of this. Sometimes passage of urine does not mean the ureter is patterned as well. Okay. Okay, sorry. Okay, all right. So again, because sometimes even if the child can pass urine, sometimes they ada hypospadias. What is hypospadias? Farah Imanina seems to like trying to say something. I can't hear you. No one can hear you. Dia tengah cakap dengan orang lain tu.
Urethra opening dia dekat bahagian bawah instead of dekat normal position.
So it's not at the proper site where it should be, ya. Dia ada banyak degree dia, ada banyak level dia. So sometimes you assess that. I've seen people missing hypospadias. Actually, last week I think we have one baby with hypospadias. Masa at birth tu, because dia punya penis dia tak lepas lagi, dia punya tu tak lepas lagi, so we didn't see actually. Tapi dia buat circumcision sebab dia ada UTI, so we ask them to do early circumcision. After circumcision tu kita tengok dia ada mild type of hypospadias. You assess passage of meconium, as I told you. If the baby doesn't pass meconium for the first 24 hours, could it be cystic fibrosis with meconium plug? Could it be Hirschsprung disease? Could it be whatever the other problem is? Could it be some stenosis? Could it be septic ileus? Abdomen should be soft and non-tender. It should be not distended. Biasalah, baby dia memang akan nampak buncit sikit kan. Buncit is tanda kebahagiaan. So it's okay. But it shouldn't be distended. Don't quote me for that. So vowel sounds should be present, and you look at the umbilical cord. Umbilical cord should be normal. Ada berapa artery, ada berapa vein. You should have 2 umbilical artery and 1 umbilical vein. Dia patut tak ada hematoma dekat dia punya umbilicus, tak ada discharge daripada umbilicus dia. And you look at the skin, you look at acrocyanopsis, you look at discoimation, Epstein pulse, erythema toxicum, harlequin color, milian, putih-putih. This is normal. Mongolian spot, pot 1 stain, Sturge Weber, and look for all those things. And then look at color of the skin. If there is any jaundice, the first 24 hours is always pathological. The first 24 hours is always pathological. So this is I think we should have discussed about jaundice, exchange transfusion. We're not going to do there. Enlarge. If you see this type of finding, what is this? Ni mata ni. Apa ni? Apa ni mata ni?
Subconjunctival hemorrhage.
Subconjunctival hemorrhage. So is this abnormal ke normal? So this is okay lah. Usually, if it's not too bad, usually it's just a result of birth, process of birth. Masa dia nak passage through the vagina tu, dia compression and then sudden release bila kepala dia keluar. Kan sometimes it may cause conjunctival bleed, capillary bleeds. So these are all. This is okay. If there is enlarged breast, would you be worried? Baby with enlarged breast, would you be worried?
No.
No, why?
So it's hormone from the mother.
Yeah, this is because of maternal hormone. Sama juga dengan some babies yang ada vaginal bleed. That's also because of maternal hormone. So Mongolian spots, nevi, this is milia, CTEV. Okay, so you do detailed neonatal examination, you look for abnormalities. So there are some abnormalities with some disease. Okay, all right. Exactly 56 minutes. Any question? So we'll try. The group that has the session today is a bit lucky because we have 1 baby. We actually have 3 babies, but the 2 I would allow you to come in. There's only 1 baby that is suitable for newborn exam. Any question? Boleh buat, simple lah. So this is basically head to toe examination. It's just about for you to identify what is abnormal, and it's head to toe. You start from the head and at the toe. Okay, all right, fine. Yes.
Okay, I want to ask about the anal patency. I read in the book. It said, please insert thermometer into the anal canal if imperforate anus is suspected. Is it practical?
No, okay. So basically you assess the anal patency. So dulu we used to put the thermometer. Dulu kita pakai even yang mercury punya thermometer tu. But now no one should use mercury thermometer anymore. No one. Because dia boleh pecah, dia boleh macam-macam. Mercury is dangerous as well. So you should not use mercury punya thermometer. But you can use other thermometer. The problem is other thermometer sometimes you nak kena letak plastic, the plastic is a bit sharp. So we don't usually use thermometer anymore to assess anal patency. But what we should do is actually we can use rice tube. We pass through rice tube. But you need to assess anal patency.
For the breast enlargement just now, so the breast of the baby will like akan mengecil ke? Kalau
it will normalize, but it will take time to normalize. It will take time to normalize. It's not a problem.
Alright.
Okay, any other question?
Doctor, about slanting, in some race, like the slanting is normal, right? So when how can we know is this normal or abnormal?
So if it's not as, sebab tu you kena tengok parent dia muka macam mana. You kena tengok parent dia muka macam mana. Kalau parent dia muka Melayu, betul-betul Melayu kan, sawo matang apa semua kan, tiba-tiba slanting macam Chinese, something is abnormal lah kan. Ataupun dia down slanting, the opposite macam tu kan, it may be something else as well. So that is why sometimes I've seen several lah. We think the child is dysmorphic, tapi bila tengok muka parents dia, oh okay, sama, then that's fine. But again, it's not easy to look at the first 24 hours. So semua orang akan nampak dysmorphic the first 24 hours. Okay, alright, exactly 1 hour and 3 seconds, 5, 6. Okay, alright. I think that's it. So the group that has the session with me, you should meet me at NICU at 2 p.m. today. And then we need to think when we can do the birth asphyxia. I suggest tomorrow morning at 8, but 8:30. But if you cannot do at 8:30, please tell me, then we can arrange other time. Tomorrow afternoon is not okay as well. If not, we can do at night lah. Sama ada malam ni ataupun tomorrow night. Malam ni pun a bit difficult. We'll see. Okay, alright. Let's end our session with tasbih kafarah. Assalamualaikum.